Okay. Well, good morning, everybody. Welcome to Grand Rounds. As y'all can see, I am not Joelle Miller. Hopefully she is having more fun right now than we are. So hopefully she's enjoying being retired and not here. To those of you who don't know me, who I've not met before, I'm John Moore. I'm a general pediatrician in Daleville, and Don has somehow talked me into taking over Grand Rounds for the next little bit. So thank you, Don. We appreciate it. So today, we're lucky enough to have Lisa Denny from Healthy Families here today. She's going to talk to us a little bit about what she does, a little bit about what the services her group has, how we can help them, and how they can help us. So thank you, Lisa, for coming today.
Thank you. So as Dr. Moore said, I'm Lisa Denny. I'm the Director of Healthy Families here in Roanoke. And so some of you may be saying to yourself, Healthy Families, I've never heard of that. Well, it's because we are brand new. Literally, I've been hired in November, and we started serving families in January of this year. We are a program of Children's Trust here in the Roanoke Valley who's been in existence under a variety of names since the 1980s, so for a long time now. But Healthy Families is our newest program here, and I'm going to talk to you a little bit about the issue of child abuse and neglect, which is what brought Healthy Families here to Roanoke, about the model, and then sort of our process in terms of referring families. So if you have families who are eligible for our services, you'll know what to do. So our objectives for today is for you guys to learn about and recognize the cost of child abuse and neglect, not just on the individual, but on the family and the community, because there is great cost as a result of abuse and neglect. Recognize the importance of prevention, because that is what Healthy Families is. We are a child abuse prevention program. And then to acquire new knowledge about the Healthy Families model. The model is a national model. It's not just something we created here in Roanoke, even though that would be great if we did. But it is a national model, and it's actually an international model. It is in a couple of countries outside of the United States. So when we look at statistics, the statistics around child abuse and neglect in this state are alarming. And in this community in general are alarming for the size of this community. So in the 15-16 fiscal year, we had almost 6,500 children who were in founded cases of abuse or neglect. And what that means is that the Department of Social Services investigated and determined, yes, this child was abused or neglected. It's not that these were the reports that they had or the complaints. These were the actual children who were abused in that year across the state. The majority of them, and historically this is the case, about 56% were for physical neglect, and that is historically what we see in the research. In Roanoke alone, we had 400 children. Okay, that's just Roanoke City, okay, not Roanoke Valley, Roanoke City. 400 children who were in founded cases of abuse and neglect, and 293 of them are currently in foster care. That is an alarming number, if you hear that, because that puts Roanoke City in the top 10 for abuse and neglect in kids in foster care across the state. That is not a place we want to be. And I will tell you, that is a place we have been for as long as I've lived in Roanoke, and I'm going on 20 years now. That's an alarming statistic that none of us should be happy about, and we need to do something about. So when we think about the consequences for abuse and neglect, there are a lot of consequences to the individual child who is abused and neglected. We see that they have higher levels of mental health issues, so depression, substance abuse, developmental delays because of the lack of stimulation they've received as they were growing up because of the neglect, social problems, teen pregnancies, lack of school success. I mean, really, if you think of any of the negatives that happen in a community, kids who are abused and neglected experience those things across their lifetime. It's not one of those things that once the abuse stops, things get better for them. These are chronic problems that occur for these children, and they do include chronic illnesses. We see kids who have more illnesses, whether it be heart disease, lung cancer, all of those things as they get older because of the chronic abuse they experienced when they were growing up. So this is not just a short-term problem that impacts these children. The cost of abuse and neglect is enormous, and I saw some of your facial reactions to some of these numbers. But when we look at the cost, obviously healthcare cost is huge. And I would even say that I bet these numbers are a little low because they're a little bit older than if we looked at recent numbers. But still, the healthcare costs are extraordinary. The loss of productivity because of all of the consequences that I showed you in the previous slide. These individuals are less productive as kids and then growing up as adults. They struggle with a lot of the daily activities in terms of finding jobs, being successful, gaining higher education and things of that nature, all as a result of the abuse and neglect that they experience. Kids who have been abused or neglected are higher likelihood to engage in criminal activity as they get older. So those juvenile justice costs, criminal justice costs as they become older are exorbitant too. And this is all from something that if we find and can support families, we can prevent. And all of these costs could be reduced considerably. I'm not going to say they can be eliminated because they can't be, but they can be reduced considerably by identifying kids who've been abused and then providing families with support as a way to prevent the abuse from happening in the first place. So when we think of child abuse and neglect, the only way to really think about it is using that risk and protective model in terms of what puts families at risk and what are things that we can do to help prevent it. So the risk factors, as the definition says, are just measurable characteristics that heighten the probability that a family is going to abuse or neglect their children, or that a child is going to experience abuse and neglect. And there are a lot of risk factors that the research tells us are common amongst families where abuse and neglect has occurred. Immaturity. We have a huge, and have had for the past 20 years, a huge problem with teen pregnancy in this community. Moms who are teenagers who are having babies are at higher risk for abusing and neglecting their children than a mom who's in her 20s, just because of that immaturity. We know at what age do kids' brains fully finish developing? It's not in their teen years. It's not until they're in their 20s. So think about if you have a teen mom, her brain is not fully developed yet, and now she has the responsibility of raising a child. So that immaturity is a huge issue that we experience here in Roanoke. Substance abuse, the opioid issue that we are facing in this community is placing families at higher risk for abusing and neglecting their children. We see it in the media all the time. Parents who are high and doped, and then all of a sudden the child's in the car with them. The parents who've passed out because they overdosed and their child's in the car. Those things are happening across the country, but they're also happening here in Roanoke. So we have families who are engaging in really risky behaviors as it pertains to illegal substances who have children in their home. We have crack homes where crack and heroin and all those things are being produced, and children are in those environments at the time that production is occurring. So that is one of the major risk factors that we are seeing, again, escalate across this country, but also here in Roanoke. And intergenerational trauma. I'll talk more about this one in a minute. There has been a lot of research that shows parents who've experienced childhood trauma themselves are at higher risk for abusing and neglecting their children as a result. The most basic is that we parent the way we know and the way we experience. So if you experience life in a negative environment in terms of how you were parented, you are more likely to do the same with your own children. So that intergenerational trauma that's taking place with these families is placing these kids now at greater risk. So this is the study I was just referring to regarding trauma. It was done back in the 90s, looked by the CDC and through Kaiser Permanente. And what the research was is it looked at, I think it was 16,000 individuals who were insured by Kaiser Permanente. So we're talking about middle-class working families who had health insurance. So we're not talking about low-income families living in poverty, families who are uninsured. These are working-class families, individuals who were insured by this private insurance provider. And so what the research did is it looked at their experiences in their childhood. And it had a number of different variables that they were looking at. And the families just had to answer yes, no, whether they experienced any of those things in their childhood. And all of those things were determined to be called their ACEs. And that's their adverse childhood experiences. And so when the research was done, they found that the more ACEs that an individual had, and this was a longitudinal study, the more ACEs the individual had, the more likely they were going to have issues in their life later on in life. And the biggest one being is that they were more likely to have negative health outcomes and a shortened life expectancy. So trauma really does impact your life whether you realize it or not. There is an awesome, and I can't say awesome enough, TED Talk done by Dr. Nadine Harris-Burke. If you just Google her name, her TED Talk comes up talking about this ACEs study and the research that she has found that she has done throughout, I can't remember what country, what state she lives in, regarding those adverse childhood experiences and their impact on later life. It's 15 minutes, or maybe a little longer than that. I highly recommend it if you have a chance to watch it because it's very interesting information that she has found and experienced it within her practice. So how does trauma affect parents? We know that it's going to have effect. It's going to have an effect on their life in terms of their health, but in the here and now, it has an impact on the way they operate in the world. So the first one being is that they have difficulty making decisions, making healthy decisions that keep themselves or their child safe. So again, you have more likely families who've experienced ACEs, who've experienced trauma, are more likely to use substances, illegal substances, whether it be drugs or excessive alcohol, because they cannot make those choices that are safe for them and healthy for them. They find it hard to trust people. These are the patients you're going to run into who are going to be so guarded on the information they share with you because they don't know you. They don't trust you yet. They may never trust you. And that's one of those barriers that sort of comes into play into helping these families because they are very leery of anybody. They have huge issues with trusting, not just trusting in professional relationships, but personal relationships. So they have a tendency to attach themselves to individuals who also have a lot of ACEs and a lot of trauma and can understand where they're coming from because there's that what's referred to as that trauma bond that occurs between these individuals. Again, they cope in unhealthy ways. They have a hard time controlling their behaviors, and they can become numb or shut down in their response to their children. And that's where the neglect piece comes in. These families become numb or they don't know how to respond in a healthy way to their child, so they just kind of ignore them and then end up neglecting their child's needs as a result. So what is child abuse prevention, which is what the focus is of what I do every day? Our goal is obvious. It's to prevent child abuse, to stop violence from ever happening to kids. Okay? That's the overarching goal of why we have child abuse prevention, is just to stop it from happening. Our focus is to provide safe, stable, nurturing environments and relationships for children. And like I said, when we think about child abuse prevention, we look at that risk and protective model. Our focus is promoting protective factors. And those are the things that we want to encourage in families as a way to lessen the impact of the risk factors that might be present within the home. So some of the protective factors that we're looking at, when we look at what protective factors are, it's that safety net that we provide to families. So it's the safeguards that are put into place to help parents parent more effectively, even during difficult situations as a way to lessen that risk. So we all know there are times that life goes kind of crazy and things are a little more stressful than normal. But if you have protective factors, and we'll talk about what some of them are, if you have those protective factors in place, you're more likely to be able to cope with those stressful and chaotic times. Unfortunately, the families who abuse and neglect their children frequently don't have protective factors, or they don't have ones that they can heavily rely on. So when they are faced with those stressful situations, things just become out of control because there is no one they can resort to and no ammunition, healthy ammunition, I should say, in their backs that they can use. So some of the protective factors that we're looking at, nurturing and attachment. Kids who are nurtured, who have a safe bond with an adult, that's a huge protective factor that can help them overcome a variety of issues. Parents who have knowledge of parenting and child development, that's one of the key pieces that is missing for a lot of families. If they are a part of intergenerational abuse or trauma, all they know is the negative parenting that occurred to them. And unless they make a conscious effort to move beyond that and a conscious effort to do something differently, they're going to continue that pattern because of that lack of knowledge that's out there. Resiliency. Obviously, we want to promote that resilience. We want to promote social connections with families. Families who are socially isolated are at higher risk for abuse and neglect than those who have a community behind them. And when I say social isolation, I'm not talking about people living in a big city, because you can be living in a big city and be socially isolated. I'm talking about having people that you can rely on, having that connection with someone, whether it be family, friends, church, work, wherever, but having that connection of someone that you can pick up the phone and call and say, I'm stressed, I'm overwhelmed, I need some help. Families who are socially isolated don't have that, or the people that they do have that are those connections for them perpetuate whatever the negativity that's happening. And then, like I said, concrete support for families. And that support can be through professionals, support, whether it be counseling, family support programs, physicians, or anything like that, but some type of support that can provide these families with that education and that resource for when they need it. So what is Healthy Families? In a nutshell, Healthy Families is a family support program targeted at preventing child abuse and neglect. Our primary focus is to work with what is defined as overburdened families in our community as a way to help increase their protective factors so that we are reducing their risk for child abuse and neglect. Typical programs across the country enroll families during pregnancy or within the first 2 weeks after the baby is born, and that is what the model tells us we have to do. The model has been research tested and evidence-based, and this is what the research shows us, that the sooner we get involved with the families, and the hope is in utero or immediately after the birth, the sooner we can build that relationship with those families, the more likely we're going to reduce child abuse and neglect. The research has shown that in communities that have long-standing Healthy Families programs, their child abuse and neglect rates are lower than in communities that do not, because it is providing that targeted support to the most overburdened families. Like I said, it's a central access point for expectant parents for accessing any resource. Healthy Families is a firm believer that our model and our program is not appropriate for everybody, and that's fine. But we are appropriate in terms of being that access point to access families or to point families in the right direction for the services that they need so that they can be healthy and successful. We have a very detailed and screening and assessment process that we use, because how can we help a family if we don't know anything about them? So the screening and assessment process helps us to learn what is going on with this family, whether it be their own childhood experiences, what currently they're facing in terms of their child's development or in terms of their pregnancy, and then we link them to the services that are most appropriate. For those families that meet the criteria in terms of the most overburdened, we can offer them home visiting services until their child turns 3, potentially until their child turns 5, if the parent is willing to commit for that amount of time. So again, we're talking about intensive services with a long duration for the hope that we can then have a positive impact on the outcomes for the child. So the overarching goals within the Healthy Families model is to improve pregnancy outcomes and child health, to promote positive parenting, to promote child development in terms of helping kids to develop in a healthy, and then obviously with the primary goal of preventing child abuse and neglect. And those are the goals across the country, not just here in Roanoke. So Healthy Families America, it is a national model, like I said, that is also international in a couple of countries. Was created back in 1992. The first location, which I would love to move there to be there, is in Hawaii. So if we all want to move to Hawaii, we could be where the first Healthy Families program was. But it was created back in the 90s because of the results of states finding that their child abuse and neglect rates were starting to increase, and that there needed to be something to make the environment safer and healthier for children. Currently, there are 620 sites nationally and internationally. It's in 35 states, so it's not across all 50 states, but there is a movement in many of the states where there is not a Healthy Family site within their state to start adopting these types of models. Like I said, it is evidence-based. There's been considerable amount of research done on the Healthy Families model and the positive impact it has on families and on communities in general. It is the only, to my knowledge, national home visiting model that requires local programs to adhere to specific best practice standards and accreditation. Our site, we came on right after the state accreditation occurred here in Virginia, but our site will be accredited every 5 years by the national program to determine that we are doing things in adherence to the model. So we know if we do, we are going to have these same types of outcomes that I shared before with the program. And the national model says if you don't do them, then you cannot call yourself a Healthy Families program. So it's a very strict program in terms of best practice standards, accreditation, and then ongoing reporting to the national models to make sure that we are doing what we're supposed to be doing. So if we look here in Roanoke in terms of the families that we're serving, like I said, we began operation on the 23rd of January. It's going to be a day that's going to stick in my mind forever. It was when we accepted our first referral. And to date, we have received, let's see, I think it's 18 screens, and we are currently doing home visiting services for 9 families. And I'll talk a little bit more about why those numbers are low, because there's a reason for it. But if we look at the statistics of the families that we are working with, about 90% of them are unmarried. 100% of them have an education less than a high school diploma, and I'm talking about not even having a GED, so they did not complete high school, did not graduate, did not go and get their GEDs. Their average age is about 20 to 25-year-olds, but I will tell you right now we do have 2 teen moms on our caseload who are 17. The racial background is about 75-25 African American and Caucasian. That just happens to be what it is right at this moment. When I talked about that we have statewide best practice or national best practice standards, we are also a part of a statewide initiative. So there is a Healthy Families Virginia that oversees the operation of all of our local programs. There are local programs surrounding this area. So Roanoke was the last one of the newest programs here for this part of the state, but there are programs in Franklin County, Martinsville, Danville, Henry County, Halifax County, Lynchburg, Bedford, all of those, Stanton, and sort of going up 81 and then 460 area. I will say going down 81, the programs do not exist. So there are currently no programs in the New River Valley, specifically Healthy Families programs, in the New River Valley that covers like Pulaski, Radford, and all of those. You go a little further down, there are programs that cover Bristol, Big Stone Gap, and those types of areas, but the New River Valley is another area that seems to have a gap in terms of service. But if you look at, in terms of the achievement, we do have statewide goals that we have to report on, track, and obviously show we are meeting these goals. So for the fiscal year 2015, 92% of the prenatal employees delivered babies weighing at least 2,500 grams. 94% of the kids who were involved in the program had a provider, were linked to a pediatrician within 2 weeks after their birth, and then continue to receive services from that pediatrician. One of the things that we know as a huge support to families is being linked to a primary care provider. When their child is linked to a pediatrician, their health outcomes are hugely improved because of that ongoing care and monitoring from that pediatrician's office. The support that the parents receive that lessen the risk of child abuse and neglect is increased because then the parent knows they can contact their pediatrician when they have questions regarding the child's development or medical issues pertaining to the child, so they're not just ignoring things because they have that linkage and that community support. And then again, obviously their immunizations, which you can see further down, is that 90% of the children received 100% of their scheduled immunizations as a result of having that strong linkage between the family, the child, and a primary care doctor for them. So those are important statistics. And these are all things that we will be tracking here in Roanoke. We move on to look at, obviously we know if we improve the interactions between the parents and the children, we're more likely to have, again, positive health outcomes. So for the state for that fiscal year, 94% of the parents demonstrated positive parent-child interactions or showed improvement. We have a specific tool, again, it's an evidence-based tool that we use to observe and assess parent-child interactions. 90% of the parents, their children, if they had optimal home environments for their kids. One of the things that we also look at is delaying pregnancy. We know if we baby space babies, we're more likely to have positive outcomes for families. So if we don't have families who are having babies every 12 months or or even closer than that, we're more likely to have healthy child outcomes. So we found that in the teen population, 85% of the teen moms delayed a second child by 24 months. Some of them it was longer than that. but there were some who had a second child right around 24 months. 87% of non-teen moms delayed subsequent births by 24 months. So obviously that is something we are striving for through education. We talk to the moms about the importance of spacing their babies. We talk to them about birth control, about why it's important to maintain their own health so that they can be productive and supportive of their child. So all of those things are things that are discussed. So our Roanoke service model, like I said, has been in operation since January. We are specifically targeting expectant parents under the age of 28. You might be asking yourselves, why that age group? Well, the reason is that's what the research tells us. The majority of births here in Roanoke occur to moms under the age of 28. So that made the most sense for that to be our target population. Healthy Families is a voluntary program. We can't say to a parent, you have to participate. We're going to encourage them, and my staff are very good at selling the program to encourage parents to participate, but it is completely voluntary. Other agencies can mandate, like social services can mandate a family to participate, but when they talk to my staff, the response is that this is a voluntary participation. We are focused on the individual needs of the families that we're serving. We are strength-based. We most definitely follow that strength-based model to make sure families understand there are positive things happening in their lives. Yes, there are a lot of negative things that they're struggling with, but there are tons of positive things, and our goal is to help strengthen those positive things at the same time that we're dealing with whatever the challenges that they're facing. But we're very much strength-based. We're free of charge. And some people are amazed to hear that. How can a program like this be free of charge? It is. Because we know families are not going to participate necessarily to a voluntary program that they have to pay for. So it is free of charge to any of the families that we serve. There are no restrictions in terms of income, insurance, or anything like this. This is a universal prevention program. It is open to any family who meets the criteria and who scores appropriately on our screening and assessment tools that I'll talk about in a second. So they don't have to have Medicaid. They don't have to have private insurance. They don't have to be low income by whatever the poverty guidelines are. It is open to any family who could benefit from additional support to help them through their parenting experiences. Currently, our target area is the City of Roanoke, County of Roanoke, City of Salem, and Craig County. We are looking at, as we get our feet on the ground, whether we're going to expand outside of those communities, and those are conversations we'll have down the road as we continue, as we get ourselves established here in the Roanoke first. Obviously, that's our primary focus right now. So our referrals come from a variety of places, including Carilion Clinc. Carilion is a huge supporter of Healthy Families and referring families to us through the OB/GYN clinics, through the hospital in terms of the NICU, PICU, labor and delivery, and all of those things. So it's a huge support from us. The Departments of Social Services, we've been getting a number of referrals from them on families that they're working with where there's been abuse or neglect of an older child, and now mom says, whoop, I'm pregnant now. And so they've decided she could benefit from some services for the child that she is pregnant with. We have partnerships with a number of human service agencies in the Valley who specifically work with at-risk populations, so the homeless shelters, the local mental health agencies refer families to us, and all of those sort of residential programs that work with high-risk populations. So those populations like those moms who are recovering from substance abuse issues or are trying to get themselves clean. We've received referrals from all of those. So we're very diversified in terms of who we accept referrals from. But obviously right now the hospital system is our greatest because of the fact we're targeting pregnant moms. So we utilize here in Roanoke a two-step referral process. Some communities use a one-step referral process, but we utilize a two-step because, again, it helps us get information about the family. So through this process, we have what is our screening tool, and I'll share that with you in a second, that our referral agencies fill out for us, or a parent can fill it out themselves. It's a quick little 10-question thing, and all they mark is true or false regarding this, and that helps to give us a score. Once we receive that, the second step of our process is an actual parent survey. We utilize the Kemp Family Stress Checklist, which again is an evidence-based tool that can assess the stress that families are experiencing. This tool is implemented on a one-on-one basis with one of my staff members and the family. and it's done in an interview. The interview usually takes about an hour because we're gathering all kinds of information. We're gathering information about the parent's own experiences growing up. What was that environment like? Was there any violence, substance abuse, mental health, or any of the things like that? What is the parent's knowledge regarding children and child development? What are the stresses they're experiencing now in their life? Who are their support systems? What are their expectations about their child as their child grows up? Do they have certain unrealistic expectations regarding their child's development and all of those things? So it's a very intensive assessment that we do. But again, like I said in the beginning, we can't appropriately service a family if we don't know everything we need to know about them. Because, like I also said, not all families that we screen and assess are going to benefit from healthy families or be appropriate for healthy families. And this helps us figure out what is the service that is most appropriate for them in this community. Because Roanoke is a resource-rich community. We have tons of resources, but frequently our families don't know what they are. And so by having the Healthy Families model, we can help pinpoint and direct families to the services that would be most appropriate to meet their needs. So this is the screening tool that we use. It looks a little different when it's on a regular sheet of paper. But this is the screening tool that we use. And again, this has been research tested by Healthy Families America to show that how parents respond to this gives us an indication of what their level of risk is for abuse and neglect. There are a couple of them that are automatic. If a parent answers true, the research tells us that these would be automatic positive screens, and that is that the caregiver is single, separated, widowed, or divorced, that they had late prenatal care entrance, no prenatal care, or poor compliance with prenatal care, or they had previously unsuccessfully sought or attempted an abortion. I don't know why those were the categories that were determined to be the highest risk, but those are. I know that the tool is actually going through the process of doing some rescreening and additional research to see if this still fits, because this was done back in I want to say it was back in the 70s, but was when the tool was created. So we're looking, obviously, at a national level whether this needs to be modified. But those are the automatic. If a parent answers true to either of those three, it's an automatic. If a parent answers true to 7 or more of the items on there, or they answer unknown, if they answer true to 2 or answer unknown to 7 or more, those would also be automatic positive screens on the tool. So that would take them to that next step of being offered the full parent survey and the full assessment. But this is what, like I said, a parent can complete it and just answer the questions. A service provider can complete it by talking to the parent, or we've even had some service providers who've been like, well, we've got that information in the family's record. We can just get it out of the record, be able to answer as many of those questions as possible, and then provide it to us. So if we have a family who screens positively, moves on to the second stage, which is that parent survey, and then that generates a score. The KEMP stress checklist generates a score at the end of the survey when you finish the whole assessment. If that parent scores positively on that, they're going to be offered home visiting services. But if at any point in time the parent says, I don't want to do this, or they don't score positively, we're still going to talk to them and say, well, is there anything that you do need that you might be interested in? And so we're going to, again, find those services in the community that can help support them. We're not going to just give them a phone number and say, call him, and he can help you with this. We're going to help that family make that connection, whether it be we give them the information, we encourage them to call while we're there, or we provide, and then we provide that follow-up to make sure that they've been connected with whatever service that it is that the family needs. Because we know we are not the program for everybody. And there are some families who are not going to need the intensity of the services that we offer. They need something sort of on a step-down approach. Or they need something more intensive that we can offer. For instance, if they need intensive counseling services or intensive therapy to deal with whatever trauma they've experienced, we're not the program for them. But we're going to make sure that they get to that program, because our goal is having healthy child outcomes. And the only way we can do that is by servicing the families or linking them to the service. So for families who do participate in Healthy Families, we meet with them on a weekly basis after the baby is born for about an hour a week. And like I said, we can stay with them until the child turns 3 or potentially until the child turns 5. Prenatally, if they're early in their pregnancy, we meet with them twice a month. As they get closer to the delivery, we will meet with them weekly. So when they hit about, I guess it's about 36 weeks or 33 weeks, we will start meeting with them on a weekly basis to help them get prepared for the birth of their child. The levels of service change as the families meet and reach their goals. So we're all about family goal setting, whether it be for the whole family or individual members of the family. And as families achieve those goals, we'll change the level of service. So we'll start off weekly for at least the first 6 months. We have families who may stay weekly after that. But for some, they start to achieve their goals. They might move to every other week, and then down to the longest duration would be monthly. We would never meet with a family less frequently than monthly, so that we're having that constant communication. Like I said, we stay with them until the child turns 3, potentially till the child turns 5, or the family chooses to discontinue services, and we utilize an evidence-based curriculum. Again, the whole Healthy Families model is based on research. So from the top piece in terms of what we are looking at achieving to the families down to the individual home visits, everything we do is based on what the research tells us. And the model that we use in terms of those parenting classes, our parenting education is all focused on what the research tells us these families need. And the curriculum that we use has gone through extensive research. Any questions?
So let's say I have a family in the office newborn visit, and I think, gosh, they could really benefit from this program. I know in the past that a lot of families can be a little leery when they hear of, hey, these are people that are going to come to your house, because they think CPS. I want CPS coming to my house. They don't want them coming to theirs. What's the pitch? Like, what's in it for the families that you can pitch and say, hey, here's what this program offers you individually?
I think the biggest pitch that we've been giving to families is that this program is tailored to support what's happening with you. We're a strengths-based program looking at supporting families so that they can have positive outcomes for their children. We're not CPS, but you're right. These families are families that have experienced great trauma in their lives, and they've seen CPS show up at their doorstep probably many times in their own childhood. But the biggest pitch is that parenting is hard for any family, and that this is a program to support you in the positive things that you are doing with your child so that you can have a healthy outcome for your entire family as your child grows.
Just have several questions. I'll throw one in here. But do you interact with, along the line, Dr. Henderson's point, what is your interaction with the courts, with CASA, with DSS, in terms of if your staff observes, obviously these are high-risk families. Mom says, gosh, I'm doing cocaine every day, and I mean, there's got to be a legal obligation sort of there that puts you in an awkward spot. You want to be a confidant, you want to be supportive, but when you see actual behaviors, what is your legal obligation to report, and who do you report to?
That is a great question. My staff are all mandated reporters for child abuse and neglect. We are all social workers by education and by our ethics. We actually sign a code of ethics through the National Association of Social Workers that states that we are mandated reporters for child abuse and neglect. So if we witness or a family reports to us something that is concerning to us, we don't have to prove that it's abuse and neglect, but if they report stuff that is concerning to us, we are obligated to report it to the Department of Social Services. And yes, that is something that we talk to these families about in their initial home visit. One of the things that all of our families sign is a rights and confidentiality agreement, and it illustrates what their rights are through this partnership, what our expectations are if they sign up for those services, the importance and the bound that we have for confidentiality, that we will not release information except with a signed release, or if we have concerns that abuse and neglect is happening in their environment. So yes, that happens literally day one of that visit. Yes, ma'am.
Yeah, just a quick question.
Sure.
Out of curiosity, with the expansion of Carilion Children's to the New River Valley area, do you think that this program will expand there eventually?
I can't say it out too loud because 2 of my board members are present, but my gut is yes. At some point in time, once we get, that's something that Children's Trust does very well in terms of meeting the needs of communities and with programs that we know that we offer here in Roanoke. And that expansion model is something we've already done with a number of the programs that we have at Children's Trust. So yes, I think at some point in time those conversations are going to occur down in the New River Valley because there is a huge need, specifically down in Pulaski, because I think they are ranked in the top 5 for abuse and neglect across the state. So yes, I think the big focus right now is we need to get our feet grounded here in Roanoke. Like I said, I've only been back on staff since November. Once we get that situated, I think conversations are going to continue to occur to expand down in the New River.
Hey, first off, thank you for that talk. I think it was really interesting. I think it's a really good way for us to think about what we can all do to affect some of the social determinants of our children's health. Thinking forward, I know you guys have only been here and active for about 3 months, and you have nine clients now. What capacity do you have, and what goal do you have for yourself as far as clients you can service?
Yeah, and that was the piece that I left out. One of the things that the model requires is that we maintain small caseloads. Again, when we have that intensity of service, my staff need to be able to have the time to spend with the family. As well as we know when we're working with high-risk populations, it is extremely stressful work. And so my staff do experience, and the research tells us, have a high experience of burnout because of the intensity of the service. So the model has dictated to us what we can do. So right now I have 2 staff, not including myself, who are the ones who are out doing our home visits and our assessments. So my family support worker, who's the one who her primary caseload is the weekly home visits with families. The model says when she is working with families on a weekly basis, she can have no more than 15 families on her caseload. When she starts to get to that point where she's got a combination of families, she can go up to 25, but never any more than 25. And the model gives us strong reasons for that. We are in the process now of dually training my assessment worker who does the parent surveys to maintain a caseload of under 5 families, because we know that as we continue to educate and teach people about the model that we're going to start to see more referrals. So she's going to be able to maintain a caseload of about 5. So that puts us at a capacity right now of no more than 30 at any point in time. We were able to get the program started here in Roanoke as a result of expansion money set up through the legislature. It's actually money from TANF money that's been set to the states for the first, so that programs could start operating for at least 2 years and then start looking at others. So at this point in time, we're in information mode. We're gathering information regarding numbers, support from the community, with the expectation that we're going to have to continue after the first year to look for additional funding sources beyond what the money that's designated from the state to be able to increase our capacity. Because my gut is it's going to be there, the need. The need is there, so we just have to figure out the best way to fund it.
I had 3 questions. Sure. One is our OB clinic itself would probably overwhelm you in terms of, how do you currently interface with them to identify either in the hospital or in the clinic setting currently, because it gets back to capacity issues. I'm sure that would be a tremendous thing. Number 2 is, what is your capability of your staff in terms of interfacing with existing programs like SNAP and WIC and things like that to help provide, do you have a way to do that? And lastly, do you offer the opportunities that you're trying to get in ideally late pregnancy? Correct. Do you offer full options and make them aware of Liberty Godparent Home and other supportive things that, in fact, these are tremendously stressful, oftentimes unwanted pregnancies and so forth? And I want to make sure that that's always, at least I like to think that it's always on the front burner of discussion with your clients that and I don't know if you're aware of and utilize Liberty Godparent Home, but phenomenal resource in this region that is underutilized, frankly, because there's not a social stigma with single parenting anymore.
Right, you're right, there isn't at all. Let me get through each of the questions. Okay, so the first one being the OB clinic. We have actually had a very successful meeting with all of the nurses within the OB clinic just last week and created procedures of how they are going to handle screenings and referring families to us. So literally my staff was there yesterday to drop off the supplies and the information that they need to be able to share with the families. The Healthy Families model is big on you don't maintain waiting lists. So one of the things that we are looking at is, again, I know Roanoke is a resource-rich community. We are going to set up a process that every certain number, whether it be every odd or every whatever screen that we get, we're going to offer the full assessment. And then If we cannot fill that, if we cannot help that family because our caseload is full, we're going to refer them on. We are never going to keep them on a waiting list for them waiting for when services would be available, because it could be way after the baby is born. So we're going to refer those families on. So at this point in time, we have encouraged the OB clinics to refer anyone that they feel would be appropriate, that they feel needs support. Because we need to, again, we need to know what the numbers are to get a sense to be able to make that case for the need for further. But for those families that we cannot serve because of the caseload restrictions, we're going to make sure we link them to a service that is available that can support them. In terms of my staff's knowledge of community resources, I was very fortunate to be able to hire staff who are long-standing Roanoke residents who've been doing this work for years. So they are strongly knowledgeable about the resources. They knew about things that I didn't even know about, because it's been a while since I've been within home visiting services. So they are extremely knowledgeable about all of the resources that are available through the health department, through other community agencies, when it comes to financial benefits, safety regarding like car seats and pack and plays and all. They know where everything is, and are making those linkages for our families as soon as they're aware that the need is there for that type of service. In terms of other types of things, yes, most of the families that we are working with are later in their pregnancy, but I will say we do have a mom right now who is very early in her pregnancy who's having those conversations in her head about, is this what I want for my life? She's 17. Can I do this? Can I support this child? Can I raise this child after she's born? And so we're having those conversations with her. It is not our job to tell her what to do. It is our job to educate her on the options and on the resources that are available to her.
What type of adoption services do you guys discuss?
We don't give any specifics. We talk about if she indicates to us that adoption is what she is looking at, then we'll get more specific. At this point in time, we just started forming this relationship with her. We're educating her on that adoption is an option and that there are great adoptive organizations. And because again, we don't want to put the cart before the horse until she says to us, yeah, I think I do want to look at adoption as being the option. And then at that point in time, we'll bring in the specific resources that are available.
Any other questions in the room? I know I had one online while you were presenting. It was kind of a question around if we have a patient that is referred to us from one of those areas that has another Healthy Families organization in their community, how do we interface with them? Do we contact them directly? Is there a listing somewhere? Would we go through you and you would come and do some kind of site visit here and then refer? How does that work with other organizations?
We could do it any of two ways. You can either refer directly to them by contacting, and I know if you go to the Healthy Families America, and if you just Google Healthy Families America or Healthy Families Virginia, it's probably easier. They show a site listing of all the different sites across the state and their contact information. But sometimes you don't have time to do that because we're all busy. So probably the easiest thing is just to give us a call, and we'd be happy to take their information, obviously if you have a signed release, and then we can help to sort of pass that information along to the program that would be most applicable or appropriate for them. Yeah, that's definitely a service, because again, we want to hook these families with the services they need, and that's how we do it.
Okay. Any other questions in the room? I can oh, all right. Hang on.
Sorry. I know that you can't answer to the your program right now, but in terms of Healthy Families, sort of long-term research, like after these families or the kids turn 3 or 5, what are you find? Is there any long-term studies about what's happening with these families when these kids turn 15 or 16? Or do you have any comments about that?
I can say anecdotally, I don't have any strong data, but I know anecdotally they have shown that kids who have sort of grown up through the system in terms of participating in Healthy Families programs until they're 3 or until they're 5 have better outcomes in terms of their education. They're more appropriately ready for school. In terms of anything beyond that, I haven't seen any, but I'd be happy to look for it and then get it to you.
Okay.
Well, I also assume that once you, sorry, Alex,
no,
once the 3 to 5 is not, transition plan, or you've been so intensely involved and then it's like, okay, we're done, or you're doing great?
There are other, we can refer to other programs. Here in the Roanoke Valley, we have the benefit of having CHIP, so that they continue until the child's in first grade, I think is their new expansion. So we could refer on for those families who need additional support. The nice thing about that, the 3 to 5, is at 3 years old, a lot of these families, their kids would qualify for Head Start. And there's tons of support within the Head Start model in terms of a family support worker that works with them on a regular basis. Once they hit 5, they're in the school system. So there's that support that happens that a lot of us experience when our child enters school that can help to make those linkages again to those families. And if it's a family who really needs beyond everything that we're going to do, we can link them to mental health support through some of those private agencies. The CSB, which is for here in the area, is Blue Ridge in terms of their counseling and additional support. So that's one of the things. If it's a family that they've graduated from our program because of the age of their child, but they still need support, we're going to find what's available in the community to help support them. Because, again, we know we've supported them for all these years. They've hit a certain milestone. We drop them. What are the chances are that they're going to continue to be in that positive outcome? Probably pretty slim. So we need to, again, wrap them around the supports that they need so they can be successful. I mean, the 35, it's 620 programs. They all vary. Right now, our funding is primarily through the TANF money that's been set aside from the Virginia legislature. But there are also other pots of money on a state level as well as a federal level, as well as local community support for the program. Right now, like I said, our primary funding is through TANF because we're in the startup phase, but those are the things that we're looking at as we move forward past those first 2 years. And then there's ongoing support through the Virginia legislature for healthy family sites.
I'm going to come to you.
Yes. Okay. Yeah, Children's Trust is the overall agency that Healthy Families is under. So we look at child abuse and neglect across the continuum. We are a United Way impact partner, so we receive funding from the United Way, from all of the local governments for which we serve, through private foundations and annual donations. We actually have one of our signature fundraiser at the end of this month, because April is Child Abuse Prevention Month, is our Golden Halo Awards, which is an award ceremony highlighting and spotlighting the good work of individuals who do a lot to prevent and treat incidences of child abuse and neglect. And I'm going to embarrass her for a second just because I can. Amy Kegels, who is in the room with us today, is the Golden Halo Award winner for the medical field. So she will be at our celebration on the 28th, so the end of this month. But so the funding that Children's Trust in general receives is extremely diversified. The agency has been in existence since the 1980s under a variety of names. We have a variety of programs. We have a Children's Advocacy Center, which is our interview facility that interviews children who've made an allegation of abuse, predominantly sexual abuse, and we interview them on behalf of the police and social services. Another new program is our Conflict Resolution Center. We merged with them, I guess it was last year sometime, so that we offer mediation services for families in the Roanoke Valley. We also have a CAC down in the New River Valley servicing those communities, so that's why when the question was asked about expansion, it's a model that we are familiar with in terms of expanding down to the New River. We also do child abuse prevention education targeted to children in the schools so that they know how to keep themselves safe from abuse and neglect and how to report it if it's something that's happening to them. And then our final program is CASA. We merged with CASA back in the early 2000s, I guess it was, with the CASA of the Roanoke Valley. So now CASA is a program of Children's Trust where we send and train volunteers to be the voice for children in the court system. So these are kids who've been placed in foster care as a result of abuse or neglect and are now involved in the court system as a result. So we have, like I said, a quite diverse. We look at child abuse and neglect across the entire continuum, from prevention to treatment to advocacy on behalf of kids here in the Roanoke Valley.
Is Children's Trust organized state by state, or is there a national?
No, there is not. Each of our programs has either a local, a state, and some of them a national affiliation, but Children's Trust is our local program focused on child abuse and neglect.
Okay. Any other questions in the room then? No? All right. Thank you very much.
Thank you.
Okay.
if you're on the line, sorry. If you have any questions that you'd like to submit to our presenter, you can always email me at outreach@carillionclinic.org, and I'd be happy to get them. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.